Getting started promptly at 8:01. This has never happened. Actually, 8:03. We have four outstanding medical students that are present today. The first is Jonathan Dahmer. I will make sure I have it, University of South Alabama. Thank you, Jonathan. Right.
Unmute. Okay. Morning, guys. My name is Donovan. For those who haven't met me, today I'm presenting on ARN. I'm going to do my best to keep it within 10 minutes. So yeah, let's get started. Click it. All right. So a little bit about me. I'm from Hazard, Mississippi. It's a small town in Mississippi, and me and my dad, we actually raised cows whenever I was growing up. He had a corporate job, but on the weekends we'd go out and we'd just kind of feed the cows, and I try to play with them because I was young. I go to school in Mobile, Alabama. One of my mentors, a beloved former resident here, Dr. Stuart Ball. He's amazing, very nice guy. And then outside of medicine, I love sports. I love to listen to music, and then I love to exercise, which people here are really friendly. They like to give you high fives when you run. So I've really enjoyed that. So kind of getting into the presentation. So we have a 60-year-old Caucasian male who presents for a retina consult for decreased vision. He stated that 6 weeks ago, he's had a sudden onset of floaters and cobwebs. He denies flash of the light or any trauma or surgery. And he states that 2 weeks before that, he had shingles on his right abdomen that was not treated because the lesions were in the stage of resolution. So past medical history, he has rheumatoid arthritis, which he's on methotrexate and Humira for. He had a right neck biopsy, or right neck mass that was biopsied on physical exam when he was first admitted. And he had some lung findings that were negative for any organisms. He was nearsighted, or he is nearsighted, and he had some lattice OU. And this is just kind of like a little chart that kind of gives you an idea of just the progression of the patient. So physical examination. So in the right eye, he was 2200. Left eye, he was 2030. Pressure was overall pretty good, a little bit higher in the right eye than the left. And then pupils, there was a concern about an APD, but in the notes in the future, they said that there was no apparent APD, so wasn't really concerned there for the pupils. He did have some restriction in his visual fields. He was partially restricted 360 in the right eye. And then on SLE, he had some cell in the right eye only, and then he had cataracts bilaterally. And then the bulk of this patient's findings were in the DFE, which I'll kind of show you guys here. So he had 1+ vitritis. He had some vitreous hemorrhages and debris. He also had some hemorrhages in the macula, and he had this really distinct 360 retinal whitening, as well as some perivascular white punctate lesions and hemorrhages as well, and also some pigmented lattice 360, but no RD was noted, which was really important, and I'll kind of tell you guys why in the future. So OCT MAC, so this patient, so as you can see, the right eye is the one below. It was pretty poor quality, so we weren't really able to tell much from that, but we can see in the left eye, it appeared grossly intact, which was good to see. And then we saw some thickness over here in the right eye, but the left eye was overall pretty normal. So our differential was ARN, acute retinal necrosis, progressive outer retinal necrosis, CMV, toxo, lymphoma, and then bacterial fungal retinitis. As you can see, this differential really kind of stemmed from the patient's state of being immunocompromised. We felt like that since we just felt like looking at his clinical presentation and just his pathognomonic DFE, that ARN was the most likely diagnosis compared to the other ones. But I'm going to really focus on the top three because of time, and I'll kind of give you guys some distinct kind of differences in the top three. So moving on to the patient's clinical course. So since we felt like he most likely had ARN, we decided to do a tap and inject with ganciclovir. Unfortunately, the tap wasn't really processed correctly by the lab, so we never really got a confident, reliable PCR sample. And we did not decide to move towards biopsy because we felt like that the results from it would most likely not change management. And he was already really improving on his physical exam His vitritis was improving, his visual acuity was improving. So we were confident that we had the right clinical management going on. And as far as pertinent studies, he was negative HIV, he was RPR negative. He was negative for TB, but he did have a positive B-cell lymphoma FNA, which only fed into his already immunocompromised state with the steroid-sparing agents that he was on. We also treated him with intravitreal injections of ganciclovir. He's received 3 injections so far, and we started him on Valtrex 2 grams TID and atropine in the right eye only. We did not start Durezol drops because he, like I said, he was improving inflammation-wise. He didn't have much cell on subsequent visits. And like I said, he had improving vitritis. And we also decided to hold systemic steroids because he was going to be receiving it with his chemotherapy, and he was already on his steroid-sparing agents. He started R-CHOP on the 26th, and we performed repeat Optos, and it showed no expanding lesions, which were good. And we're still following him today. We're still doing ongoing assessment and management of this patient. And then this over here just kind of gives you just like a little succinct view of just kind of this, because he had a lot of visits in the span of 2 weeks. So it kind of gives you a better idea of what was going on. So just a little bit more about ARN. So it's commonly caused by viral infections, VZV and HCV most commonly. CMV and EBV can be associated with it as well. But according to the reading that I read last night, it's not, the evidence is limited. Risk factors. So obviously HIV, AIDS, previous history of hepatic infection, certain HLAs, and being on steroids. So this is normally seen in healthy immunocompetent adults in 50s and through 70s. However, diseases don't read the textbook, so it can really kind of present and who it wants to, and this patient is a great example of that. So signs and symptoms. So unilateral acute vision loss, however, it can present bilaterally, which in a paper that Dr. Weinstein sent me, it said actually 70%, up to 70% can actually be bilateral. They can also have some redness, photophobia, pain, flares, and flashes of light. And then you just get inflammation, episcleritis, scleritis, AC inflammation. Then you get the pathognomonic retinal whitening and opacification. And then some complications. I would say the most common one is the retinal detachment, and I'll kind of tell you guys why. So pathophys, so it's really hard for me to understand signs and symptoms without understanding the pathophysiology. So the acute herpetic phase is essentially when the virus is replicating in the vitreous humor, and it causes the vitritis. And then you have this infiltration of the retina by the white blood cells and by the virus, and this causes the retinal opacification. And then you also get some inflammation in the retinal arterioles, which causes the occlusion and the ischemia, and then that kind of gives you the whole picture of ARN. And then in the late cicatricial phase, you already have a thinning, weak retina. So in this phase, you have the vitreous humor, you have like contractile membranes that will form in the vitreous. And that will cause RDs, which are up to, I believe it's like 50 to 75% can occur in patients with ARN. So it's a very, and some doctors will do prophylactic laser. However, the consensus on whether that's actually effective is kind of still out there, because patients can still get RDs even after prophylactic laser. So, and then primary prevention, from my reading last night, chronic antivirals can prevent ARN from occurring in the fellow eye, the previous unaffected eye. So that's something that's pretty interesting. So, and then here I talk about just diagnosis. So the American UVI Society, they have some diagnostic criteria. And then this is just kind of the standard of treatment here. This is exactly what we're doing with this patient. We started him on valcyclovir. He's getting ganciclovir injections, and he's also on, he's on the topical steroid drop because the inflammation was improving, but he is on atropine, and we do plan on doing some maintenance on him as well. And then prognosis really varies. If a patient gets an RD, obviously that will really hinder their ability to see in the future because it's an RD. But we're hoping that this patient, will have some sort of vision in that eye in the future. So like I said before, CMV was on our differential. I would say out of all these bullet points, the point where they say typically no vitritis was really key here. And then also the periphlebitis, which is like when the retinal veins have like a silvery faint glow to them. I thought that was pretty interesting. But this patient, like I said, we really felt like he had a pathognomonic presentation of ARN. However, we didn't assume that other diagnoses could be considered, so that's why we considered that. And then as it describes here, it kind of has the pizza pie appearance in the retina, which I thought was really interesting. It kind of looks like ketchup with like cottage cheese. I think that's what they say. Yeah, ketchup with cottage cheese. So I thought that was pretty interesting. Also a nasty combination, by the way, in my opinion. And then porn. So I created this chart. It's not comprehensive by any means, but basically what I say is that porn is most commonly seen in patients with AIDS and immunocompromised, and ARN is in immunocompetent patients. But that is basically, that's what the textbook says, that, obviously patients, it can present the way it wants to. But the most important thing I would say is that porn has minimal inflammation and few hemorrhages, whereas ARN, you'll have significant vitritis and retinal hemorrhages as well, which in this patient, like I said, we felt like he had a pretty pathognomonic presentation of ARN. But as Dr. Weinstein said, you can't really assume things. You have to really kind of work things up. And unfortunately, we didn't really get a clear PCR finding. So that really kind of hindered our ability to really say what we felt like it was most definitely. But however, like I said, just looking at the patient, we felt like ARN was the best diagnosis. So I'd like to thank Dr. Padilla and Dr. Bastos and Dr. Weinstein for giving me a lot of great feedback and looking at my PowerPoint probably 3 or 4 times. And then just to thank the Department of Ophthalmology for allowing me to rotate through. I don't have a program where I'm from, so it's been great to hang out with you guys and just kind of get to see what the day-to-day is like. So those are some of my references, and thank you guys for your time. You can send any questions on them.
Questions or comments? For Dr. Great talk. Glad to hear the patient's improving. Yeah. Okay. Spared any questions.
Yeah.
We'll get the transition going while we're getting set up. So our next presenter is Casey Johnson, and I don't know. We'd have to. Well, I'd have to do it like a Google map check to see who came the farthest between Logan and Casey. But Casey is from Washington State University. Is it? I think you're a little farther.
Both are far.
And thank you so much for your presentation today.
Right.
Is it like 2,600, 2,700 miles?
I have to Google it, but it's probably close to, yeah. First time. Like Spokane, it's not, if I was from Seattle, it'd be a little further.
Guess you're right. I think the Bonners, it's like 2,200.
Okay, then that's probably all Spokane is. Probably like maybe like 6 weeks.
Inspired me to bust this guy out. Bear with me today. Oh,
You don't have what you usually.
you have like a bunch of pictures in there. Area.
You. All the time.
Oh, smack me a little.
Yeah. Are you serious?
You know, like carry my 78.
So the 90s. What else? This is probably. I don't know how you might. That's just me personally.
But then they're like,
Well, I'm gonna.
That was good, man. I like. But we have at least more people. This is -22.
I'm gonna make
For me.
Why?
It's not your fault. Yeah, but he's funny about the. All right. Hello, my name is Casey Johnson. As we just mentioned, I'm visiting from Washington State University, which is located in Eastern Washington, Spokane, Washington. And I'm to be presenting a case of cicatricial conjunctivitis. All right, so just quickly to go over the case, we had a 53-year-old Caucasian female who reported to the clinic with a chief complaint of ocular irritation lasting for 8 months. She reported the ocular irritation most often occurring in the corner of both eyes and feeling a blister-like sensation underneath her eyelids. And then she also noted that in the mornings when she woke up, her eyes were crusted shut. Her best corrected visual acuity was 20/25 on the right and 20/40 on the left. Examination of the lids lashes revealed flaking and crusting. The inferior temporal palpebral conjunctiva of both eyes showed mild symblepharon. Also present was bulbar conjunctival injection with 2 distinct non-ulcerated growths that were smooth and firm upon palpation. And then also the corneas of both eyes showed mild SPK and DFE was unremarkable. So this patient then was referred to an oculoplastic specialist for a conjunctival biopsy. And based on those biopsy results, clinical signs, and the patient history, all of that was used to make a diagnosis of ocular mucous membrane pemphigoid. So I'm just going to review mucous membrane pemphigoid. It is a systemic secretizing autoimmune disease that affects orificial mucous membranes. In up to 70% of MMP cases, the eyes are affected. And just of note, OCP or ocular cicatricial pemphigoid is kind of an outdated term that was used. Now it's largely been replaced by ocular mucous membrane pemphigoid or OCMMP. And then also of note, OCMMP encompasses the diagnoses of linear IgA disease, mucosal dominated epidermolysis bullosa acquisita, anti-laminin 332, anti-apelligrin, and anti-laminin 5 pemphigoid. It is the leading cause of secretizing conjunctivitis in developed countries. Incidence is about 1 per million in European countries. It's more common in Caucasians. And the average age of diagnosis is about 65. However, it's been documented anywhere from 20 to 91. In those cases of younger patients typically have a more severe disease presentation and more aggressive disease presentation. So a quick review of the pathophysiology. It's a type 2 hypersensitivity reaction. Those antibodies are attack the basal epithelial membrane of the conjunctiva. And as most autoimmune conditions, it's thought that environmental factors as well as genetic susceptibilities are each believed to play a role in that initial loss of tolerance to one or more components of that basal membrane zone. And then what happens is that stratified, non-keratinized secretory epithelium then undergoes a squamous metaplasia into a non-secretory keratinized epithelium. So just a quick differential diagnosis for a cicatricial conjunctivitis. You have SJS and TEN, paraneoplastic pemphigus, graft versus host disease, dermatitis herpetiformis, pemphigus vulgaris, surface neoplasias, including OSSN and SCC, trachoma, which is actually the most common cause worldwide, adenoviral conjunctivitis, conjunctival trauma, atopic keratoconjunctivitis, ocular rosacea, and ectodermal dysplasia. So some key history questions to ask. So first, is it bilateral? Only 6% of cases of OCMMP present unilaterally. So if you do see a case that looks like OCMMP that is unilateral, you should have a high suspicion of an OSSN or SCC masquerading as, masquerading as what looks like OCMMP. Any topical drug exposures, acute or chronic, atoxic conjunctivitis can present very similarly. And then is there any involvement of other mucous membranes? Other ocular involvement is preceded by the cutaneous or oral involvement in the mucocutaneous and immunobilous disorders, and the severity of the ocular signs in those are generally milder as well. So the clinical presentation, classically you'll see involvement of the medial canthus with the loss of the caruncle and plica semilunaris. And often that's the initial presenting sign, and as well, that presenting sign is more frequently present in OCMMP than other secretizing disorders. And then you get into kind of the classic presentation, which is you see a felt work like reticular fibrosis and infiltration of the tarsal bulbar conjunctiva, which leads to fornicele foreshortening, symblepharon formation, secondary superficial entropion, and ankyloblepharon. And those are kind of the main clinical signs that you use to stage this disease. And then ultimately, in many patients, this leads to a tear film instability, severe dry eye, and eventually leading to a skin-like conjunctival keratinization over the surface of the eye. And this disease can lead to unilateral blindness in up to 30% of patients, and bilateral in up to 20%, so very severe. So diagnostic workup, first you do a bulbar perilesional conjunctival biopsy, and then run it through direct immunofluorescence. Just kind of note on the DIF, it's neither sensitive nor specific marker of OCMMP, as the DIF is often negative, especially if they undergo treatment or remission of the disease. And in the literature, about a 66% positive biopsy rate in the disease. Also of note, SJS-TEN, drug-induced scarring, pemphigus vulgaris, lichen planus, ectodermal dysplasia, and lupus can also test positive for DIF, and the results may be indistinguishable from that of OCMMP. All of this to be said, OCMMP can be diagnosed with a negative DIF if other causes of citrocranial conjunctivitis have been ruled out and that clinical picture fits. So treatment. The aim is to control that immune-mediated, the type 2 hypersensitivity inflammatory disease, and then therefore prevent progression. So the mainstay of treatment is with immunomodulatory agents, and traditionally they have used a step-ladder approach. So kind of to review that, with a disease with mild inflammation, you typically start out with dapsone, or you can consider a sulfapyridine. Methotrexate has been used, but I think in the last 10 years or so, it's kind of fallen out of favor within the literature. And then if you still see disease progression, you can jump up to azathioprine or mycophenolate. And then kind of from there, you can combine drugs for resistant cases or jump to something like a cyclophosphamide or IVIG. Typically with cyclophosphamide, you also do a short course of oral steroids to bridge. And then as you see remission of the disease, you can plan withdrawal strategies to step back down on that step ladder. So I worked on a project on this disease. Our manuscript is titled "A 10-Year Review of the Management of Ocular Mucous Membrane Pemphigoid or Private Practice Experience." And we did this research out of it's two oculoplastic surgeons in Spokane, Washington, called Northwest Eyelid and Orbital Specialists. So the beautiful Pacific Northwest, we were located in Spokane there. And I kind of highlighted that blue region as we have a very large catchment area. We see patients from Eastern Washington, North Idaho, Western Montana, Northern Oregon even. And all of that is to say that we had an N of 22, which is actually a pretty big number for this disease. The largest study ever published on this disease was about 100. And it was the first study we ever published in a private practice. So we thought it was kind of a unique experience in that sense. So just briefly to review our results, we showed that mycophenolate and then mycophenolate plus rituximab both seem to have the best results based on 4 variables. We qualified treatment outcomes at 3 months after initiation of either monotherapy or combination therapy. And those represent a sustained complete resolution, response, which is basically a partial response, not complete resolution, and then failure, which was either discontinued at 3 months due to an adverse effect or no response. Kind of the biggest finding of our study was that we statistically, using 3 of the 4 variables, showed that dapsone is inferior in the treatment of OCMMP to mycophenolate. So based on our data as well as the literature review, we kind of presented an updated treatment algorithm for the treatment of this disease. We felt that we showed, and as well as the literature is kind of trending towards dapsone potentially as an inferior treatment. And we feel that despite, or whatever stage of disease, mild, moderate, or severe, we feel that you should consider going to mycophenolate rather than starting with the dapsone. And we also feel that if disease progression occurs on mycophenolate, you should strongly consider jumping straight to combination therapy. And we saw great results with mycophenolate plus rituximab. At that point, then you start kind of throwing the kitchen sink at it, considering switching to an azathioprine, doing triple therapy versus IVIG. And we feel that cyclophosphamide really should be kind of used as a last resort, as we had one patient who went on it and ended up actually dying from severe septic reaction a couple months later. So yeah, they're my sources. Any questions? Thank you all for a great rotation, especially the residents. You guys have been great teachers and really enjoyed my time here.
Very nice presentation. Thank you for that summarization of the management options. This is Dr. Kapoor. My question was, who is co-managing the treatment with the immunomodulatory agents? Who in your study was the person or the group that was doing this? Was it dermatology, rheumatology?
Yeah, we had a group, Arthritis Northwest, who is a rheumatology group, private rheumatology group in Spokane, who was co-managing. And then anytime we saw esophageal disease or dermatologic involvement, we would send them to both their primary care provider and GI or dermatology to help treat that part of the disease.
Thanks. That's one of the challenges we face here is finding someone to co-manage that, the side effects from the medication. So
Definitely.
And I've got a
You
question,
need to partner with
Dr.
the group in Washington. That means.
This is Dr. Katz.
Yeah.
You know, so we've or I've only.
We lost you, Dr.
We
Katz.
lost you.
We heard you at first.
I think
hear
he
us?
dropped out of the Skype, or not Skype, Teams.
Okay. Maybe he's driving.
Yeah, it is Zoom. Oh my goodness.
Okay, thanks, Madison. While he is timing back in, we'll let him, we can even have him comment perhaps after, just.
You know, I'm back. I'm back.
Oh,
I
good.
think.
Okay.
Yeah, I was just going to say that you know, I anyway have stopped using Dapsone a long time ago, but the methotrexate, I mean, even on your study there, it looked like that worked fairly well. That's usually my first line still, because it's much easier to manage and to get going, and always oral steroids. Particularly the beginning, all this stuff, all those immunomodulators take time to work, so you got to hit it with that. I would add, and then the last thing I'll say is that you know, the age range. I mean, I don't know. I mean, it's linear IgA disease. It sometimes comes at a little younger age, but the classic pemphigoid, I mean, it's almost always over 60 years old. I mean, if you see it younger than that, I first thing is thinking it's not that. So I don't know what your age range in your study was, but that's very going down to the 20s. I've never seen it.
Yeah, I think our study, our average age was about 73 or so. So similarly, we found a little bit older than what the literature said.
Well, yeah, I mean, I'm not sure what literature you're looking at, but they always have been classically taught, you know, over, if it's under 60, you got to start similar to like when you're talking about GCA or something. It's very unlikely to be in younger people. And like I said, now you're milking some other things in there with linear IgA disease and a few other things that may sometimes happen younger, but again, yeah, that's almost always older people.
Thank you.
Thanks, Dr. Katz. Okay. Another great presentation there. So next we have Robert Rickert, who has come the shortest distance from just north of the river there, and University of Cincinnati. So welcome.
Everybody, thanks for having me. For those of you I haven't met, my name is Robert Rickert. Like she said, I'm just coming from Louisville, so very close. And
Sorry, Louisville.
just
University of Louisville. I'm sorry.
Cincinnati's great too. And I'm just going to talk to you a little bit today about a case we had recently with Dr. Katz and Dr. Williams with corneal transplant, a DSEC, and then just a little bit about graft rejection and longevity of these transplants in general. Okay, so like I said, it's kind of the objectives to discuss a case of repeated corneal graft failure, learn for those of us who are new to the field a little bit about what different types of corneal transplants are available, how often they're performed, then compare graft rejection rates and graft survival rates based on the review I did. Here's just a little artist rendition of a corneal transplant failure. I think we can all appreciate it's good this is not how it actually turns out. So the case is about Mr. S. He's a 76-year-old man, and he was referred to UK in August of last year for a cornea evaluation by an astute provider who suspected corneal transplant failure. And this is a picture of not of him, unfortunately, because I couldn't find any, but This is similar. He'd had a DSEC and had gotten swollen and edematous and had a very hazy view, and that's what this is depicting as well. So he had a past medical history of Fuchs' dystrophy and bilateral cataract surgery and coronary artery disease. And then he had that bilateral DSEC 10 years ago at the Cleveland Clinic. So it had lasted a pretty long time. I mean, or he'd had it for a pretty long time, we'll say instead. And on his initial exam, August of last year, they noted the thickened and swollen cornea. His pachymetry was 688 on the right, 1031 on the left, and his visual acuity on the left was only counting fingers at 1 foot. And he actually disclosed to the team that he had stopped taking his steroids a week after the transplant. So they suspected that may have something to do with it. So they started him on steroids and scheduled him for a repeat DSEC, which Dr. Katz successfully performed at the beginning of this year. And then there's I won't go too fully into the clinical course here, but so he successfully performed the transplant, started on the recommended treatment of the steroid and then the antibiotic. And then initially everything seemed to be going okay. But after a month, they noticed things were pretty swollen, not improving as well as they would like. So they gave him a little bump on his steroids, saw him back a couple of weeks later, noticed that started to be more concerned about graft failure because things were still swollen and edematous. And then by the time April rolled around, which had been almost 3 months later, they just realized that given how persistently hazy and swollen the cornea was and how things just weren't improving given all of the steroid dose, that primary graft failure had occurred for a second time. So they scheduled him for a repeat DSEC, which was successfully performed by Dr. Katz and with Dr. Williams on the 23rd, and that's where I came in. And then they also did a superficial keratectomy at that time too. So this kind of made me wonder, just because I didn't know much about this, like what are the types of corneal transplants available? How often are they performed? So I did a little bit of little background here for those of us who don't know. So you got 3 of the main types I'll talk about today are the PK, which is a full thickness resection. Then you put in a full thickness graft. There's a little illustration. And then a DSEC, which is removal of the patient's descemet membrane and endothelium. And then you put in donor endothelium, descemet membrane, and a little stroma. Then thinner than that is the DMEC, which is take out the membrane and endothelium. And then you put in membrane endothelium, no stroma this time. And as you can see, at least in the US, PKs are really going down since the advent of DSEC and DMEC kind of coming up. And now those EK procedures comprise more of the total work done here in the US, at least based on this report. And these days, you continue to see a lot of these. And then that kind of made me wonder, how often do these transplants fail? If we're doing them a good amount of the time, but if I'm like a 50-year-old guy and I've got Fuchs' dystrophy and they're scheduling me for this transplant, that if you're gonna get a heart transplant, that may not last that long, but how long do we expect this corneal transplant to last? And how often might this fail outright? So that's what I sought to answer, and didn't get the clearest answer for you, but I'll try to give you what I got. So the rates of graft rejection do vary, and there are a couple of types of graft rejection. With the most common being endothelial, and that there's actually a higher risk of immune rejection if they've had a previous graft, which makes sense. If they have active inflammation, if they're a younger age, if they have a couple other factors. And then there actually was a study in the cornea donor study, which is only PKs, which showed that the failure rate depends on the number of rejection events, which is a patient who might come in and they have their vision's down, they've had some discomfort, and if you could characterize that's a rejection event, you could say based on this study that they had maybe a 10% more chance of that graft failing. And then based on these couple short-term studies, at least, you can see that PK rates in the short term, they might be rejected maybe 15% of the time. And there was this one study by Anshu et al. In 20 years showed that their failure rate was only, the rejection rate, sorry, was 16%. But they didn't characterize DSEC or DMEC. And then when you start to consider DSEC and DMEC, you can see that those rates drop, which kind of makes sense, as those grafts are getting thinner and thinner. And that's partially, I'm sure, why they're getting so much more popular these days. And then similarly, the survival rates vary too. And this is where it gets a little bit more, the data is a little bit less certain. But there was this large review article that I found that, as you can see, had pretty wide ranges for survival rates for all of them really, but the DMEC. And they followed up the PKs for 15 years, which is a pretty long time, I would say. But then if you looked into that, they had included patients with a variety of etiologies like Fuchs' dystrophy, bullous keratopathy, people who'd had regrafts. And then as I included some other representative studies showing that, if you had a regraft, your likelihood of that surviving at least 5 to 10 years is substantially lower than your first graft, which I think makes sense. And then similarly, actually down here, a study by a group out of Singapore showed over in 5 years that patients with Fuchs', I didn't include this data here because it looked like too much info, but patients with Fuchs' had a substantially higher survival rate in the short term than people with bullous keratopathy. So there's kind of a lot that goes into it. But I think on the whole, we can say pretty good confidence, at least based on my research, that if you got a PK, you could expect that in the 5 to 10 year range, maybe to survive 90% of the time, maybe low 8, maybe 80s too. Then if you had a DSEC and a DMEC, you should be thinking that that's probably going to last like 5 years with a 95% chance. So you should be feeling pretty confident about that for the patient. And then to return to Mr. S, since his transplant, he's been seen in clinic and it looks like everything's progressing normally this time. His physical exam, his graft is detached. It's still hazy, but that's to be expected this short term. He does have an epithelial defect from that keratectomy. And he does have a little neovascularization present superiorly, but overall, it sounds like things are progressing as we'd expect. And he's taking his drops this time, which we're thrilled about. And we're waiting to see him here soon. I think next week he's scheduled for a follow-up. So then in summary, I think we can say with pretty good confidence that like I was talking about at the beginning, if you're that 50-year-old patient coming to you and they're saying, hey, I want this DSEC, am I going to need 1, 2, 10 in my life? I think you could say the first time you've got a pretty good chance of that lasting 5 to 10 years, and then kind of try and take it from there. But then if they've had that repeat, the numbers go down. And if they're younger, they might have a higher risk of rejection too. So you have to get into it a little bit. But for an uncomplicated older person, I think pretty good chance. And then this is just a nice looking picture of a PK I put here. Spruce it up a little bit. So thank you. That's it. And I just want to say thanks again to everybody for having me. I really appreciate how welcoming everybody's been, especially all the residents, Dr. Stevens, Dr. Tanya Padilla, for looking at my presentation for me. Thanks.
Thanks. Another great learning point for me, especially I don't deal with this much. Any comments from our cornea specialists who are hovering in the atmosphere here?
I
Well,
can comment on the survival rate or life expectancy of EKs that I've been doing. I've been doing DSECs for about 15 years, and my small sample size, I usually tell my patients now that most of the DSECs I did are surviving 15 years or longer, and there are very few that I've had to go back and redo. So I actually tell a 50-year-old patient that they have a good chance of not needing maybe more than 1 or 2. So when I started doing them, the survival rate was expected to be 5, but it's proved to be a lot longer. And I haven't done DMAX as long, so I don't know what their survival rate will be like, but DSECs are doing well.
Yeah.
Yeah, I think it's important to mention that DSECs or any, I mean, the price, I'm not sure you pre-quoted prices, some of the studies in there, but there is, if they have a tube, I think the average survival is 2 years after a tube. And if you have glaucoma, significant glaucoma, it really knocks it down as well. So there's a lot of factors that go into it. In that particular case, the Mr. S who is presenting, he's he's got some issues, but he's not very compliant. But the first one that when I redid this one from Cleveland Clinic, it was attached day 1 and just never really cleared. So it was a primary graft failure. And the second one, we'll see, he's somewhat compliant, but he's got blood vessels creeping in everywhere, looking like he's not taking his drops despite that he claims he is. We'll see what happens. I'll let you go on.
No, it's thank you. It's good to know. And it'll be interesting. It sounds like the studies that are out there are not, perhaps we need some longer follow-up studies, since it sounds like the data that's out there is perhaps looking at a shorter range of time. We need some 15, 20-year studies to, Dr. Kapoor, you need to get your patients together and have one of our
Students write it up.
yes, write up your results. Okay,
There's
so
an idea.
thank you again. Great talk there. And, again, I'm still flushed red from my embarrassment about having your institution incorrect. I'm sorry. So last but not least, we have Logan Wolfel, who joins us from University of New Mexico.
Hi, everybody. Logan from University of New Mexico. It's in Albuquerque, New Mexico, which is here on a map, if you're unfamiliar. It's home to the International Balloon Fiesta. 100 balloons take flight every single year, and the very family-friendly show, Breaking Bad. And today, I just want to talk a little bit about a disease that I learned about while I was here, called blue cone monochromatopsia. And before we do that, just want to get into a little bit of background. Retina is made of rods and cones. We know that. There's over 100 million rods, about 5-6-ish million cones. And there's different types of cones. There are red cones, which are mostly sensitive to long wave light. They're called L cones. Green cones, max sensitivity to medium wave light. So they have M cones. Then blue cones, short wave light, S cones. And if you're anything like me, you might be wondering, why are red and green so close together? Why do they cover a similar spectrum? So I got really into the history of cones. Not those cones. But no, I did get into cone evolution. And the theory is it started with, primates started with one cone, that's M and L, and one S cone. So you had two curves covering different parts of the spectrum. And over time, that one M and L cone split into two different ones. So you can have really high discrimination between red, green, and yellow. And it's thought to be pretty helpful for fruit foraging. So you can tell the difference between this and this. And it's also kind of represented in the concentration of cones. S cones are far less numerous. L cones make up about 60% of cones, M cones about 30, and S cones, depending on the source you look at, less than 10%. And also the fovea, the very central foveola is exclusively M and L cones, and about the most central 0.3 degrees of vision has no S cones at all. And that's represented here in the schematic, lots of red, lots of green, very scattered blue. And then in the very central visual axis, no S cones at all. So what is this blue cone monochromatopsia? We also can call it BCM. It's when patients don't have the M or L cones, and they're only able to capture light with rods, and the S cones they do have. And when the medium long wave light enters their eye, they really can't do anything with it. And it's about 1 in 100,000 patients. And so how do they present? Symptoms they have? Usually really poor visual acuity, best case scenario about 20/50, because they don't have those very central cones. There's nothing in the fovea for them. They also have severe photophobia, inability to distinguish colors because they only have the one color cone. And they also can have nystagmus as an infant and severe myopia or other refractive errors. And this is actually one of the diagnoses they might try to ask you, what do you think when you just look at the patient? And it's because their whole world is right in front of them. They're so nearsighted a lot of the time. You walk in and everything is right in front of them, and they have really severe photophobia. So they're pretty squinty. So you might be able to just look at them and say, I think that's BCM. And genetics of it, it's X-linked recessive. It's located on the XQ28 chromosome. And this is the gene for it. I didn't know exactly what this was, but LW is for long wave and medium wave. So they don't have those genes. How do we diagnose it? How do we exactly figure out what it is? We can get a good idea if it's a male child and have some kind of photophobia or nystagmus. And this makes you think of some kind of achromatopsia, but it's not really enough to know it's a blue cone only, or they only have blue cones. So you could get an ERG to show lack of cones, but with retained rod function. You can get a color vision test if they're old enough to differentiate that. But really the most important thing is family history. And what else do you want to think about? You can have achromatopsia, X-linked ocular albinism, any other kind of cone dystrophy, depending on how old they are. And you can also have a different kind of rod cone dystrophy. Might be things you can think about. And what do we do for these patients? Not really a lot we can do because they already don't have the cones, but we can kind of treat symptomatically. And there's these magenta brown filter lenses we could use, These block out pretty much every wavelength except for red and blue, which is helpful because they have the blue cones and it can reduce their photophobia and also help quite a bit with style. And for reading up close, they use really high power magnifiers, might be able to help them. And one thing I thought was really interesting is that some of these patients, if their vision is decent enough, they can use these biopic telescopes to get a driving license. And they just look down and it zooms in on whatever they want to see. And I think that's pretty amazing that you can actually do that. And also just have to give a huge shout out to their website. It's pretty fantastic. They have a lot of information about the pathophysiology, what exactly it is. They have a patient tab where they can register if they want to find more people going through similar things like them. They also have a meeting every single year where they meet and try to build a support group for all the patients going through the same thing. And the thing that I thought was the most interesting is that they have an art contest for all these kids that have blue cone monochroma DCM. And I think it's really helpful to view the world from how they see it, at least get a little bit of insight into what their world's like. And just want to say thanks, Dr. Stevens, for helping put this together, other med students for going to Red River Gorge, Keeneland for existing, and then specifically Joel's Chicken. Yeah, so I got.
Any comments for Logan? There is an old story. I'm an old geek, so I have to say these stories, but Dr. Flynn was a famous pediatric ophthalmologist, and he would always say that you could make the diagnosis of achromatopsia, which is similar, from the doorway, and he'd stand at the doorway and that you'd walk in and the little kid would be in the chair going like this, shaking, turn the lights off and their eyes would open up, turn the lights off. So that was, if you ever, that was his famous discussion. Apparently he'd walk the resident and say, okay, what's the diagnosis? Turn the lights on and off a couple times. So anyway, great presentation. Thank you. Thank you. Any questions for Logan about monochrome? We do see a fair amount of this, and we were discussing this because of our gene pool in Eastern Kentucky. We actually see, we think it is a common disease here rather than a rare disorder. All right, I think we're good. That's any other issues for today or good? Is there a lecture following for, okay, all right. Sounds like it's time for a break. Thank you again to all our medical students. We really enjoyed having all of you. Yeah.